Well, thank you all for letting me speak today about something I'm very passionate about. And I promise you that this is actually a pediatric talk, and it's something that's important in pediatrics. So sometimes when people see a fertility preservation talk, they're thinking, what does this have to do with children? And hopefully we can together reach an agreement that this is something that's very important, not only for patients going through cancer-directed therapy, but other different types of therapies that can have a lasting impact on fertility. So our objectives today, we're going to just start at the beginning and just review quickly ovarian anatomy and oogenesis, as well as testicular anatomy and spermatogenesis. And then we'll review some newer risk stratification tools to quantify the risk of gonadal failure and infertility. And then next, we'll move on to understand fertility preservation options before chemotherapy and after for patients with ovaries. And then next, we'll also look and understand risk diagnosis and management of premature ovarian insufficiency after iatrogenic injury. And then finally, we'll move on to patients with testicles and understand preservation options before and after cancer-directed therapy. So I like to start this talk just by framing why is this important. Personally, the reason I got interested in this area was whenever I would have a discussion with families and we would bring up that your child may likely be left infertile from this therapy, it was one of the first times that I would see families really break down and start to cry. And then after that, I started to get lots and lots of emails in around 2018 and 19 of families who were experiencing that their young child was going through menopause at the age of 21, 22, but that they were just learning now that they were getting ready to start a family and they're realizing that they're left infertile. And so this was something that I thought we can do better, and also led me to dig into the science and what is actually available. There's also really nice examples in literature. I don't know if anybody's had a chance to read this book, but it's called Between Two Kingdoms. And the author writes, there on the list of side effects, I saw something that upset me more than any of the bad news I'd received so far. The cancer treatment that would save my life would almost likely leave me infertile. As much as I appreciated their support, the absence of communication on something so important felt like a breach of trust early on in our patient-doctor relationship. There are other examples of this in social media. There's a really funny Instagram page called The Cancer Patient. It's pretty satirical, a little dark, but the prompt that the creator had for those of us that have infertility due to cancer treatment or diagnosis, how are we feeling today? It was Mother's Day. And someone wrote, very sad. I wanted to be a mother all of my life and cancer took that away. And then someone else describes the experience of how people tiptoe around them and try to say, oh, but you're a dog mom. And how they said, I totally understand that they don't want to exclude me, but I wish they didn't feel the need. And just how this is really has a lifelong impact on our patients that are experiencing cancer and other therapies. So oncofertility is the term that we use to describe this field of thinking about fertility preservation for patients initially in the oncology space, but it really expands beyond that into hematology for patients with sickle cell disease and hemoglobinopathies. It expands to other areas of immunology for patients that receive highly toxic therapy like bone marrow transplant, or even some of our newer cellular therapies. But this movement is really pretty young. The original recommendations and guidelines weren't really published until 2004. It was around this time that both the President's Cancer Panel put out a report on survivorship and recognized infertility as a top concern. And around that time, ASRM, or the American Society for Reproductive Medicine, started a special interest group. So what's not included on here is sperm banking, which has been around prior to this initial part, but that was really mainly what was available to many of our patients. Then there was specialized research groups that were started in 2005, and it wasn't until 2006 that the American Society of Clinical Oncology published their first guidelines for fertility preservation. It's kind of shocking to believe that it was in 2012 that egg freezing was deemed non-experimental. And this was really led by changes in methods of how you process the tissue. So previously it had been a slow freeze, and the process of vitrification had become more popular. And so the outcomes from egg freezing improved quite dramatically. And so that is what led to that change in the experimental classification. What I'm hopeful to talk to you all about is what happened in 2019, which was ovarian tissue cryopreservation was deemed non-experimental. And why that is important is that that's really opened up the fertility preservation options for our younger female patients or patients with ovaries who aren't old enough to undergo ovarian stimulation for egg freezing. So anytime that I talk about fertility preservation, I almost always start off by just giving a brief, quick anatomy and physiology lesson. And I first start by talking about that the ovaries and testicles usually have two functions. One is the reproduction. So for patients born with ovaries, the ovary contains all of the oocytes at birth that they will ever have, and that number will decrease with time. In addition to that, it has the important function of producing progesterone and estrogen. For patients born with testicles, we know that it's important for reproduction, but that sperm production doesn't really begin until puberty. And then also it has the very important function of producing testosterone. And so that's really helpful as we frame this discussion of why something is available or not available. The next thing that I do is I review ovarian anatomy. And so if you haven't thought about this in a while, the way this is a picture of an ovary. And what we have here is the outer cortex is removed. Whenever I explain this to families, I usually use a food analogy, which I know we shouldn't, but I say that the ovary is about the size of a large grape, and the outer skin on the grape is where the cortex is located, and that usually is where all the eggs are located. And so that can be helpful as I explain the ovarian tissue cryopreservation procedure. But this middle picture here is really the cortex is on the left and the inner medullary cavity is on the right. For patients with testicles, when we talk about spermatogenesis, I talk that the testicle contains many tubules, and the sperm are really formed from the outside in, and that at prepubertal patients, so Tanner stage 1 and 2, typically that tubule doesn't have a middle hollow spot for the sperm to travel through, and that the outside is lined with sperm stem cells. And that also becomes important whenever I talk about some of the more experimental methods that we have available. And that as patients go through puberty, there's maturation of these tubules, and that from the outside, the spermatogonial stem cells develop into mature sperm, and they're able to travel out. So one of the things that's really helpful whenever we get fertility preservation consults and requests is really to make sure that someone has done Tanner staging or has done some sort of a GU exam. And what becomes most important is that really for patients to be successful with sperm banking, we talk about patients being Tanner stage 3, but even more than really pubic hair distribution, it's really testicular volume that's the best predictor of success with sperm banking. Well, that's one key aspect. The other key aspect is maturity and understanding of what is required for a masturbatory specimen. So this becomes very important whenever we get consults to discuss fertility preservation, is to understand where's a patient at. So what I want to talk about now is how do we quantify risk in this patient population? And thankfully, we have some newer tools, but I'll start by talking about what are the key offenders that we think about. The first is radiation, comes in a variety of different forms. The forms that we think about obviously are proton and photon beam radiation. Those can be quite damaging. And we think about the areas not only being in the ovaries, but in the testicles, but also the brain and the pituitary axis. We also think about it in the form of total body irradiation, which can be given prior to a bone marrow transplant or any of our cellular therapies. The next that I think about is alkylating chemotherapy. So this is commonly agents like cyclophosphamide, thiotepa, ifosfamide, melphalan, things that are used prior to bone marrow transplant. But we also think about this in patients that have kidney disease or who have certain rheumatologic conditions in which cyclophosphamide is being used, usually at much smaller doses. And finally is heavy metals. So carboplatin and cisplatin, really common use in brain tumors and as well as some of our solid tumors. And then others. So we're also thinking about patients who are receiving gender-affirming hormones. So patients that are transitioning from male to female who are starting estrogen. We'll have discussions, as well as there's a slew of newer agents that are coming on board, targeted therapies. So one of the things that we've tried to do is actually quantify some of these risks. And so we know that, for instance, alkylating agents aren't all created equal. And what we will do is take the total dose of the medications being given, and we take them in milligrams per meter squared. And what we'll do is use a multiplier. And this is easily found online. If you type in cyclophosphamide equivalent dose calculator, or CED, you'll find this. But what we can do is take the different agents and then determine and multiply them out, and then get a cyclophosphamide equivalent dose, which will then be used to help quantify risk, which I'll show you on the next slide. But you'll see certain things are quite a bit more toxic than cyclophosphamide. So melphalan, which is commonly used for conditioning for a bone marrow transplant, thiotepa, which we use for brain tumor therapy, busulfan, again, all are quite a bit more toxic than what a standard dose of cyclophosphamide. I like to also just kind of give credit to the group that really started to look at this and create this whole field. So this is Dr. Teresa Woodruff. She used to be at Northwestern when she started this field, and she started the Oncofertility Consortium, which has a website which is really helpful to find some up-to-date information. And she's now, I believe, the provost at Michigan State, but she's really pioneered this work. So when we talk about risk classification and risk stratification, it's kind of a hard concept to explain to people, because it isn't always that you lose your fertility right at that very point, but it might decrease the fertility window. So to really explain this, on the left, you can see is on the y-axis is the number of primordial follicles, and then on the x-axis is age. And in the standard population, the number of eggs decreases with time, with an average age of menopause somewhere around the age of 50. And we know that this menopause occurs due to the decrease in number of primordial follicles that mature and develop and decrease with time. But what happens after radiation or chemotherapy is you can dramatically reduce this pool of primordial follicles. And this happens through a variety of different mechanisms: vascular damage, stromal damage, inflammation, apoptosis, atresia. All these things can happen in the ovary and decrease this number. So patients can either lose their fertility immediately or start to show signs of menopause in their early 20s. So I tried to simplify this a little bit. And so this is a decrease in the number of oocytes with time. And what we're trying to do by using these risk calculators is determine what group are you going to fall in. Are you going to be someone that's going to follow the normal age-related decline with the green dotted line? Or are you someone that's going to be more in a moderate risk category where it might decrease that duration of fertility? Or you're someone that might be in the high toxicity window where you're going to have a dramatic decrease in fertility. And so when we think about measuring for signs of premature ovarian failure, some of our tools that we have are to measure hormone levels like LH and FSH, which can be at a normal range of level. And then when we start to enter into decreased ovarian reserve, you can have a skyrocket in the FSH. One of the other tools that can be helpful to us after therapy is completed is the AMH. So when there's a large pool of follicles, AMH can be used. It's a marker of mature follicles in the ovary. And so if that number starts to drop off, it can be an early biomarker that can show that you're proceeding into menopause. And similarly, you saw this slide before, but where there's more of a broad spectrum, kind of different categories for patients with ovaries. For patients with testicles, it's a little bit more binary. It's either short-term infertility or long-term infertility. So patients may, after completion of cancer-directed therapy, may not return spermatogenesis for a year. But for other patients that receive a high amount, there's not like a window and then it stops. So this is what I hope to share. It might be new to many of you here. This is a paper that was published in 2020 out of the Pediatric Initiative Network from the Oncofertility Consortium to risk stratify risk of infertility. So what this does is take the alkylator dose, heavy metal exposure, exposure to transplant, radiation exposure, both to the ovary and as well as the brain at the hypothalamus, and then also takes into account pubertal status. And you can see for patients that are prepubertal, they can tolerate a little bit more alkylator than those who are postpubertal. But we really look at this as 8, 12 as being the key numbers that kind of put patients into this. And this is really work that came out of the childhood cancer study that was led out of St. Jude. In addition to that, there's different amounts of radiation exposure that can be important to that the ovary can tolerate as well. And then additionally for testicular patients with testicles, we have a little bit different of a risk stratification. There's no breakdown by pubertal status. And additionally, you'll notice the amount of alkylator drops quite dramatically down to 4. Anything above 4 puts someone in the high level of increased risk. Now, one of the first questions that I usually get is, what does that mean? What do these categories mean? And this paper didn't elucidate that, but if you dig into some of the literature, once you get in the high risk category, there's a greater than 20% chance that you'll lose your fertility, and it really is exponentially climbs once you go from 5, 6, 7, 8. So what I want to talk about is the fertility preservation for individuals with ovaries. So many people are familiar with oocyte cryopreservation, but I'll talk a little bit about that and how we think about it in pediatrics as well as in a time-sensitive case. So if someone has malignant disease or is going to be going into some sort of highly toxic therapy, typically what we can do is in their post-pubertal, we can think about oocyte cryopreservation. Oocyte cryopreservation, in the very fastest we can get it done in about 12 to 14 days. We have the technology to do a random cycle start, so we don't have to time it with the menstrual cycle. Honestly, what's the biggest barrier is getting either financial clearance or the drug delivered. There are many foundations that will cover the cost of the medications, and they get shipped to the patient, like the Livestrong Foundation and Fertile Hope and other groups. But getting that process started quickly is really the barrier to this time frame from when you're thinking about it to getting completion. But typically in our very young patients, we can use an abdominal ultrasound. We don't need to use transvaginal ultrasound to perform this. What we're able to do is do stimulation, monitor the eggs, and then around day 12 to 14, ideally harvest the mature oocytes. Usually it's done under anesthesia through a transvaginal approach. And there the eggs are vitrified and then frozen down, and usually have long-term storage at a large regional center of ReproTech. So most fertility tissue in this region is stored in Reno, Nevada at ReproTech. And then there, when a patient is interested in starting a family, that those frozen eggs can be sent back to their reproductive clinic that could then use them to either fertilize an embryo if desired. A little bit, the next question almost commonly is cost. How much does this cost? So Washington State does not have a mandated fertility preservation coverage. It's really up to the employer. We have a bill that's been introduced last year to require coverage for fertility preservation, and it's currently through the House and will be going through the Senate in the second year of this legislative session. But typically, if medications are not covered, it's about $12,000 out of pocket. And then the storage fees are approximately $350 per year. And there are financial assistance programs to bring that down to $150. If you're able to get the medications covered, usually we can get that cost down to about $6,000 out of $6,000 to $7,000, somewhere in that range. So as I mentioned, there's a newer technology that became available, and this was end of December 2019, the American Society for Reproductive Medicine put out a position statement saying that ovarian tissue cryopreservation was no longer being considered experimental. And this was really a game changer for us in pediatric oncology and in the fertility preservation field, as well as it has some really meaningful impacts for certain patient populations going through cancer therapy. So I'm just going to talk through what is ovarian tissue cryopreservation. I think it's pretty cool. So these are pictures that we have I took from our OR. So what we do is we do a total oophorectomy. We remove one ovary at the time, either at a larger abdominal tumor resection, and the patient could already have received some chemotherapy, or we do it as a standalone laparoscopic procedure, similar to like having an appendix taken out. It's a same-day procedure. We also try to coordinate it with like a central line placement. But that's not as crucial to coordinate it. Originally, that was done for insurance purposes, but we lobbied the Healthcare Association, and we can actually get coverage for this through a loophole in the early prevention and screening of treatment and diseases. And so because we screen for cancer, you have to cover its treatment. There's nuances to that, but I won't go into that right now. What we do then is bisect the ovary. We cut it in half. And then we take it across town and we immediately start to process the tissue, usually within an hour. And we take the outer cortex off of the ovary, and then we cut it into strips. Those strips are then slow frozen, not vitrified, and are initially stored on site for a couple of days, and then they're batch shipped to Reprotec. Then when a patient is interested in starting a family, this ovarian tissue can be thawed, and then it can be quilted back over the remaining ovary. And so the transplantation usually happens into the abdomen. And so it's quilted over the remaining ovary, and then a fibrin mesh is put over the top to help with vascular growth, because it's from the data, it appears that getting vascularization of the tissue is the best predictor of success. So you can transplant it over the remaining ovary from the pocket where the ovary was removed, or you can create a peritoneal window and quilt the tissue back in there. And so what led to the really change in the experimental classification were the number of live births. So there have been live births from autotransplantation of this tissue into the subcortical, all these areas here. So as I mentioned, the remaining ovary, the ovarian bed, and the peritoneal window. And there have been both births with IVF as well as spontaneous pregnancy. Now, there are also examples where the tissue is actually transplanted back into the arm. That's primarily for endocrine function. So endocrine function restores in about 85 to 95% of patients. They'll get normal levels of estrogen, progesterone, normalization of FSH. In addition to really getting the endocrine function, but there's actual work to try and stimulate that you could actually retrieve like an egg from the forearm, which is kind of wild. Now, what would be ideal is in vitro maturation. So that would be where, if you could imagine someone had leukemia and had their ovary removed, there's always a theoretical risk that you could be reimplanting tissue. When you reimplant tissue, that there could be leukemia cells present. So that's why we don't do this up front at diagnosis. We actually want a patient to get into remission. So when we do their second bone marrow, we do flow cytometry to look for minimal residual disease, or MRD. And so we actually only do ovarian tissue cryopreservation when someone is MRD negative if they have leukemia or lymphoma. But ideally, what would happen is that we'd be able to mature this tissue outside the body. And if you wanted to, you could take an egg and either form an embryo or freeze the eggs down at this point in time. The major limiting factor to this technology is actually the 3D scaffolding that's required for ovarian tissue to mature. And that's what they're really doing now, is they're printing tissue matrix for the tissue to grow on. And so there's been an increasing number of live births that have occurred from this method. But there's been really some really great examples in the pediatric population where we're starting to see success. The first one I want to share with you is about a patient with sickle cell disease who was diagnosed at age 5 and started to have some pubertal changes at age 10 with breast development, but never really had menarche. Ultimately went on to go and receive a stem cell transplant. And part of the stem cell transplant had OTC performed at age 14, as I mentioned, no prior menarche. But then had menarche induction at 15 years of age post-transplant. About 10 years later, the patient had ovarian tissue transplanted and had premature ovarian insufficiency confirmed prior to transplant, auto-transplantation of the tissue, and had 6 tissue segments grafted into the peritoneal bursa, and 5 were grafted subcutaneously. And at 5 to 21 months post the autograft, the FSH and LH were returned to premenopausal range, had normal menstruation, follicles were seen on ultrasound. Interestingly, the AMH actually still remained undetectable, but the patient had a spontaneous pregnancy with a healthy baby boy that was that was born in 2014. What you can see on the left here is a graph where there's FSH levels and estrogen on the y-axis, and then across the bottom is months post-auto transplantation. Another example is in the cancer population is in acute lymphoblastic leukemia. This is an example of a patient who had a diagnosis of leukemia at 14, went on to receive a high-risk protocol with total body irradiation and then transplant. And that again was within that first year of diagnosis. Had a documentation of permanent ovarian failure, had a first ovarian tissue transplant at the age of 29, so approximately 15, 16 years later, that was unsuccessful. Had a second transplantation at the 1 year later, and had a pregnancy established through IVF and had a healthy baby boy at 35 plus 5 weeks. And then interestingly, at the time of this publication, had a natural conception pregnancy that was progressing into the 35th week. So really exciting for this patient population. So for instance, we don't offer oocyte cryopreservation for patients with leukemia. Usually they're very sick, at a high risk of infection, commonly have high white blood cell counts, and also have a quite high risk of blood clots. So we wouldn't start high doses of estrogen and progesterone and Lupron to try and save fertility in using oocyte cryo. But what we can now offer is if they're going on to receive high dose chemotherapy and transplant, do ovarian tissue cryo. One of the other questions we get is, well, what if I didn't do anything? Something happened and we're too sick. What about fertility preservation after therapy? Or maybe I have a break in my therapy or something like that. Well, we really recommend that patients wait 4 to 5 months after chemotherapy to actually undergo stimulation. And we have a few considerations. So we really will not perform this unless if they're coming from an outside center, their ANC is greater than 750. And if they're at Children's and we're monitoring them regularly, we will accept greater than 500. And then for ovarian tissue cryopreservation, as long as someone has received less than the highest risk category so for postpubertal patients greater than 8, or for prepubertal patients less than 12, we'll actually proceed ahead with OTC if they're going to go on to receive further therapy or have a relapse or something like that. Okay, then we'll finish this off. It's not quite as exciting for patients with testicles. As I mentioned before, we really have a much lower tolerance of alkylating agents, and the outcomes are pretty binary. And risks don't vary with age, and some patients have temporary azoospermia, which can last up to a year. So this is really the change. It's a cross-section of a seminiferous tubule, and what happens with puberty and the access with stimulation of endogenous testosterone is that you start to get the maturation of spermatogoneal stem cells into mature sperm, and that's really available. It can start around age 11, 12, 13. And I said, like I mentioned before, it's really testicular size, which can be the best marker that someone would be successful. So when we talk about this with patients, we really say that ideally they would be around Tanner stage 3 and they've masturbated previously. And then we also recommend we have to talk about really not using any lubricants or saliva, and the sperm must be collected prior to any chemotherapy. We try to not make assumptions. And the other important thing if you're doing this work is you have to get the parents out of the room. We do a lot of telemed for these visits, and we also have to kick parents out of the telemed visit as well. And we commonly will get, no, I've never done that before. I don't know what you're talking about. And then the parents leave and they'll lean into the camera and say, I've definitely done that before. So it's really important to not make assumptions. We've also sent patients who are 15, 16, 17 over to the sperm bank or to one of our clinics, and they are not successful. So we try to really just break this down into small pieces. And a few communication strategies that we will use is to say, first we'll talk about an erection. Have you ever had an erection before? Do you have difficulty achieving an erection? Can you tell us, do you know what that is? Is that something you've had before? We'll sometimes talk about nocturnal emissions. And then we'll ask if they know what sperm is and ask them to explain the difference between urine and sperm. and then really just kind of step them through the process and see if they'll be successful. We can perform this in the hospital. We can also send patients over to the clinic to collect specimens. One of the questions that we sometimes get is how many collections do you need? Well, it really depends how much time you have. And then the second part is how you use the tissue or the sperm in the future. So if you have a large number of sperm, you can sometimes use IUI or intrauterine insemination. So you need a large number in volume. If you have lower numbers, then you can proceed ahead with IVF or in vitro fertilization. And now there's a newer technology called ICSI or intracytoplasmic sperm injection, where you take one sperm, one egg, and you bring them together and you fertilize and form an embryo. And so that's really the wide spectrum of what's possible. And so ICSI has really helped for the patients who might already have extremely low sperm counts due to just being sick at diagnosis, to really allow them to have fertility preservation options. What we do have available for our prepubertal patient population, as well as other individuals who might be too sick at diagnosis to do a sperm collection, is a testicular tissue cryopreservation. As I mentioned, we only offer this at Seattle Children's as a clinical trial protocol. This is for patients with a high level of increased risk of infertility, so greater than 4 CED, going to transplant, things like that. They need to be MRD negative prior to the procedure, so no minimal residual disease seen on their bone marrow. And they can't have had a previous exposure to high-dose chemotherapy. And what we do is a wedge resection. It's a small incision at the base of the scrotum, usually about 1 centimeter to 2 centimeters in size. We take a wedge resection of the testicle, collect some of the seminiferous tubules, and then we put them in refrigerated lactated ringers, and we actually ship our tissue over to the University of Pittsburgh, where Kyle Orwig, who really is the leading scientist in this area, serves as the site that processes and freezes down the tissue before it gets sent off to Reprotech. The procedure is billed to insurance, and interestingly enough, testicular biopsies just are automatically kind of covered by insurance. And the processing and freezing on the study is free, but there's a long-term storage cost that's kind of universal, anywhere from $100 to $350 per year. I have this picture of a monkey because that is the first non-human primate example of success with this technology. So the tissue is frozen, thawed, re-implanted back into the either over the testicle, or sometimes they do it in a subcutaneous space. And with the return of spermatogenesis, sperm is aspirated from the tissue where it's taken out, and then that's used to fertilize an egg and then lead to a live birth. And so this is Grady is what they named it, and it has some acronym that I cannot remember, but this is the first example of success. There have been no live births to this, human live births to date. So that's something that we share with families. For some people, they're like, yeah, that's not for me. This seems really experimental. And for other people, it's very, very important. In fact, we have had patients fully turn down curative therapy or bone marrow transplant because of the impact on infertility. It's unacceptable toxicity. So for some people, this does make that there's a theoretical potential for family building with this technology. One other thing this is, I think, really important is we sometimes look at these consults like, we just gave a little bit of vincristine, or we just gave a little bit of chemotherapy. That's not really, you shouldn't really be freezing that sperm down, even though you want to do it. And it's like, we already know that DNA gets damaged very quickly, and that you already start getting cross-linking of DNA and damaged sperm, and these sperm don't go on to fertilize eggs. And that's a strong recommendation from ASCO that any sperm should be frozen down prior to the initiation of chemotherapy. So this is an overview of all of the different options that we have available. So for patients with ovaries, we have ovarian tissue cryopreservation in the prepubertal age. And for the pubertal age, we have ovarian tissue cryopreservation as well as oocyte and embryo cryopreservation. For patients born with testicles, We have, for the prepubertal population, no standard of care, only an experimental protocol, which is our testicular tissue cryopreservation protocol. And then for the pubertal population, we have sperm cryopreservation, testicular sperm extraction, which I'll explain in a second, as well as testicular tissue cryopreservation. Testicular sperm extraction is commonly what we use for patients with spinal cord injuries, or other issues where they're either not able to achieve an erection or ejaculation. Sometimes we see it with patients that have a retroperitoneal lymph node dissection and have retrograde ejaculation. So what we'll do here is we'll take, again, similarly a wedge biopsy, and then we take the tissue over to the lab, and we actually manually kind of, with small forceps, milk the tubules to get the sperm out and freeze it that way. So that's also called TESE, or testicular sperm extraction. You might also hear a term called micro-TESE. Micro-TESE is sometimes used for patients with islands of the testicle, so Klinefelter syndrome, where there might be normal spermatogenesis, and other areas where there's not normal spermatogenesis. So you need to have a microscope in the OR to look for normal tubules in the testicle. And then that would technically be a micro-TESE, and you have someone on site looking at that in the OR with you. So I hope that I've been able to provide an update of all these options that are now available to our very young patients, particular patients with ovaries, such as OTC. And for male fertility methods are limited and really should be offered prior to gonadotoxic therapy. And really share that there's new strategies available to risk quantify. The paper that I shared with you that used cyclophosphamide equivalent dose, radiation exposure, really was the first pediatric guidelines that are available to us to risk stratify patients, and provide some risk and definition and examples for why this is critical to our patients, and it's really important to coping in the future. If you have any questions whatsoever, you can email us at any point in time, fertilitypreservation@seattlechildrens.org. We also have a full-time nurse coordinator who works on this, and that's fertility preservation RN at seattlechildrens.org. There's no dumb questions. We're happy to help meet with families, answer any questions you might have of what might be possible, or if you're worried about the risk of a medication, we can either tell you what we know or look it up and get back to you. It's a pretty small group of people across the United States and internationally. So usually within a day or two, we can get you an answer on risk stratification. And that is really all I had, but I would be happy to take any questions if you have any.
Couple technical questions. For the ovarian transplant, for replacing ovarian tissue onto the ovary or peritoneal area, how do you get the egg to go into the uterus for fertilization?
Great question. It actually just naturally migrates.
So there's not a barrier to that?
Nope.
Okay.
Yeah.
And then for the person with testicle at home on telemed, being instructed to ejaculate, what are the transportation issues, and what does he put it in, and how long does he have to get it to the lab?
Question. So a few things happen. So really where we see a lot of that being utilized is in the gender clinic patient population. So typically patients need to live with or be within 1 hour of a fertility center. They will provide them with a cup to collect it in. Doesn't have any, really, it's adjacent to a urine container, but it's a little bit, has a special lining and processing of the inside of the cup, and it's slightly smaller. But really you need to be within 1 hour of the clinic. There are a lot of online things, like overnight mail is one that we've had patients where the sperm sits and it gets shipped overnight and it's processed, but you'll notice there's a lot of things lacking from those websites, which is their outcomes data and the success rate and viability rate after collecting at home. So you really what we tell patients is it really needs to be ideally at the clinic within 30 minutes to an hour. And it's actually, they have an appointment where they're waiting for the tissue to process it immediately. And they'll freeze it down, and then they'll do a test thaw, and they'll provide us with a number of viable sperm count, motility, all those things.
With the ovarian tissue retransplant, do you see higher like pregnancy complications or birth complications? So ectopic pregnancies, preterm births?
Excellent question. And the answer is we have not. The success rate is actually almost as good, or maybe getting slightly better than IVF. The tissue itself is around, the success rate with ovarian tissue is around 45 to 50% per auto transplantation. So many times, if it's an older patient with a larger ovary, that'll be cut down to 16 strips, and maybe anywhere from 6 to 8 will be auto transplanted at a time. So you have reserve as available. The one other thing I should mention is that with the endocrine function part, there's varying amounts of how long that will last. So if you transplant tissue, it won't last, and provide endocrine function. For some individuals, it's for a year or two, and for other, it's 10, 12, 13 years, similarly with the fertility aspect as well. So really, we don't recommend just once you're done with therapy, transplanting it right back away. You want to really kind of time it with when you think you want to start building a family. But there's been no, even in patients that survive cancer where their ovaries have remained in the body, there have not been increased rates of birth defects. Even with radiation, usually the thought is that either those eggs don't get fertilized, or they are an early miscarriage. But that was actually a large analysis out of the childhood cancer survivorship study that looked at that exact question. All right. Well, please don't hesitate to reach out if you have any questions or if this comes up with any of your patients.